Thank you for the opportunity to share our experience. So we performed our first Artisse case in July 2023. And subsequently, in the same year, we performed 13 Artisse. Then in 2024, we deployed 48 Artisse and 41 in 2025. So yes, we have performed more than 100 cases in Montpellier, and my personal experience includes 68 cases. So you can see from this data how the device has become a common practice now in our center. This is the outline of my presentation. So we will begin by showing some conventional cases. By conventional cases, I mean cases where Artisse appears as the ideal tool for treatment. We will then proceed by ruptured cases, and I will try to convince you that the device is both safe and effective for this situation. And fortunately, we have some DSA 1 year follow-up, so I will show some DSA angiography follow-up at 1 year. And I will conclude by sharing some tips and tricks, and I will try to emphasize on the proper use of the stimulation software. This is a typical case of Artisse, anterior communicating artery aneurysm, 30% of cases roughly. So you can see the deployment of the device, the vasosity, with a slight protrusion. And you can see on the other case, the very good stagnation of the iodine contrast inside your aneurysm at the final DSA. It's a very common finding to have this kind of stagnation. You can see here how I would had accept the protrusion, and you can see the final DSA. Finally, the aneurysm is completely excluded the day of the treatment. On the other examples, middle cerebral artery, roughly 30% of cases. This one is a very one. You can see the triangle of the proximal part of the device protruding a bit inside the early bifurcation. And it allows a complete occlusion for safety and for my intellectual purpose. At the beginning, I performed day 1 MRI for every patient, and honestly, we have very good results, despite you can argue that it's just MRI and not DSA. So it's the day 1 MRI of the same patient. Another one, which is not quite classical for intrasaccular device, you see how the shape is irregular. We put an Artisse device. You can see the slight protrusion at the bifurcation, and you can see the 6-month follow-up, which is very satisfying. Carotid terminus is my favorite location. The angulation is perfect for Artisse device. You can see the deployment, the good stagnation of the iodine contrast, and you can see as well the final one showing a complete occlusion of the aneurysm. Another carotid terminus, I will not go into detail for this one, but same final DSA, complete occlusion of the aneurysm. Another case, I will go quickly for this one, but you can see same MRI day 1 and MRI 6 months, the aneurysm appears completely excluded. Posterior communicating aneurysm is also a good location. For example, this recent case, very good shape, round, small neck, but I think for this case, I did maybe 5 minutes of X-rays using the radial access. So it's very convenient, very quick, and this is the final DSA on the lateral view, showing a almost complete occlusion of the aneurysm. Pica, why not Pica? This was a young patient, very young patient, with a Pica aneurysm. Same 5 or 7 minutes of X-rays from the right radial access, and this patient, you can see how the stagnation is good on the final run. For sure, obviously, basilar tip and superior cerebral artery, due to their shape and generally configuration, they are very good candidates for Artisse device. We now move on to the ruptured cases. I did 8 cases. All patients, I performed an MRI at D1 to be sure the aneurysm was excluded, and at least on the MRI, it was the case for all patients, and more importantly, I didn't face any rebleeding for any patients on the almost 10 cases I performed. Another example, very irregular shapes. Honestly, 2 years ago, I would have not put a web. due to the results I have with the Artisse on the irregular shaped aneurysm, I put an Artisse for this patient, and the MRI at day 1 is perfect. Patient with a fissure syndrome, left carotid terminus. You can see the day 1 MRI, which was very satisfying. Some tips and tricks regarding the access. Most of the cases was performed using the radial access. As for other cases, you have to use, if you can, a dedicated catheter that you will place in the petrocavernous segment. The recommended micro catheter is the Ray by 13. For left pica or for basilar chip aneurysm, I like to use the left radial access. It's a very suitable access for this kind of aneurysms. When the neck is not easily depictable, you can use the eye incidence, as on this example, and you have to get the proximal triangle, the proximal parts of the device inside the eye to be sure to occlude properly the aneurysm. So this is another example with a magnified view. You can see here. Sorry, here you can see how I have the triangle proximal part inside the eye. So you have to know to which extent you can trust the simulation software. It's very important. So generally, for middle and big device sizes, above 5 millimeters, which is the most frequent case, the simulation has a tendency to overestimate the protrusion at the neck. So you have to forecast that and to know that in real life, probably the protrusion will be less prominent. For example, this example, you can see finally the difference between the initial simulation showing slightly too much protrusion, but in real life you can see how the neck is finally respected with a very good outcome at 6 months. This was a tricky case. It was at first glance not the aneurysm you want to treat with Artisse. And this was the simulation I had at this time. But you can see how the simulation is not applying the device or on the wall, on the aneurysm. So I forecasted that probably in real life the protrusion will be less visible, and you can see on the Faso CT at the final, after the final run, that the protrusion is not at all worrying. So this is the 6 months follow-up. Another example, we tend to be more cautious for small sizes. For example, for this kind of aneurysm, I will be more cautious about the protrusion, and same, you have a very good outcome. For all cases, ruptured or small, we tend to accept less protrusion. It's very important to know that. A very good outcome for this patient also. So this was the ruptured, and you can see that for this patient I was a bit cautious and the protrusion was very tiny. Fortunately, normally we will have a new version of Siemens size by the end of the year, and we performed the same case I just shown, the simulation I had compared to the simulation with a new version on the middle of the screen, and you can see how it's better. So yeah, it's expected to be released by the end of the year, and I think it will be very helpful to determine the good size of the device. This is the thing I love with this device. You can see the conformability of the device. The behavior is very helpful to conform the aneurysm walls, and you can perfectly see on the video on the screen. You can take advantage of this conformability. For example, look, the first deployment on the left side for me was not satisfying. I was not happy with that. I will put a magnified view. So the left side is the first deployment, and the right side is the second deployment. I just reshift the device, and I put it more proximally and with more push, and you can see how you can cover more part of the aneurysm compared to the left side. And it's a tool you can use with this device, the conformability. You can take advantage of that. You can see the difference of shape. It's very discrete, but it's visible on the left side, first deployment, on the right side, second deployment, we are more aggressive on the neck, on the right side. Regarding the detachment, I like to use a blank roadmap because you can see the movement of the pusher wire when it's effectively detached. So you can do a blank roadmap and you just do the scopy at the last time to see the wire moving. And an additional tip, when you are not sure that the device is deployed, you can use, it's a technical which always worked, a slight quick torque on the pusher, and I never faced any issue of detachment. For some cases, you need to protect the branch. It may be a good option. For example, for this case, I was a bit concerned by the inferior trunk of M2. So first, I put a headway 17 microcatheter in the inferior trunk. I put the rebar 18 in the aneurysm. And after the deployment of the Artisse, I was real concerned by the inferior trunk, and I just deployed a stent to protect the branch, and it was very effective. Regarding the rebar 18, some colleagues are hesitant about it because we are used to use 70 microcatheter, but to be honest, I had the same feeling at the beginning, but now I'm very confident with the micro, and once in place, you are very stable, and you can use the steam shaping in some cases. It may be helpful. A few words about antiplatelet management. The patients scheduled for Artisse are prepared similarly to all our patients. So we always have back in mind that maybe they will need a stent. So we do clopidogrel 5 days. Very important, we do the verify now the day before. If the platelet rate inhibition is okay, we just proceed, and if it's not, we just switch towards prasugrel or ticagrelor. And after, generally speaking, patients are prescribed aspirin 75 milligram daily for 1 month, but it depends. If it's very, as Monica said, it's the neck is very tiny, no issue during the procedure, I just stop. But most of my patients are prescribed 75 milligram a day for 1 month of aspirin. We now switch to the DSA follow-up at 1 year quickly. So patient with the ACOM, classical one. This is a follow-up at 1 year with no modification of shape. Another case, carotid terminus. This is a 1 year follow-up without any modification of shape as well. A man, very good results at 1 year without compaction on this case as well. I showed this case before. This was a irregular shaped MC aneurysm. I just performed the DSA a few weeks ago, and you can see how the aneurysm has gone, as well as the carotid cavernous and the carotid ophthalmic aneurysm, which had been treated at the same time using a flow diverter. So it works even for irregular shaped aneurysm, as in this example, another MCA irregular one with a very good control at 1 year. The pica I just showed, it's gone also, so it works for pica aneurysms. Do we have some neck remnants at 1 year? The answer is yes, we do have, but I think honestly that it concerns mainly earliest patients where we didn't accept protrusion. I have the feeling that now that we have a good experience and the learning curve is improved, that probably we will have less patients with neck remnants on 1 year DSA. I hope so. Do we have aneurysm filling at 1 year? We do have some case, but this case is very interesting. Why? Because I was not satisfied with the 1 year DSA. As you can see here, it's aneurysm filling. It's not just neck remnant, but the 2 years MRI is perfect. Yeah, you can agree, you can argue that it's an MRI, but I'm pretty sure that the patient will never bleed. We don't treat images. So yeah, I was not happy at 1 year, but at 2 years, I'm just very okay with that. So key messages, on the 100 cases we performed in Montpellier, we can retain that the device fits many aneurysms. We can use it for both unruptured and ruptured cases. it's quite rare to not have the good device size, in my opinion. You have to know what extent you can trust simulation software, and we have very encouraging results at 1 year, but for sure long-term data are needed. Thank you.
Thank you, Cyril. So a tremendous amount of information. Very first question is how do you size? Do you use the chart provided by Medtronic or do you use the simulation software?
I use first my experience. I do the measurement of the boss in every projection. Generally, I add at least one or 1.5 millimeters for the width. And after I do like the web, I minus 1 generally, or 2 if I have increase of 1.5 or I have an increase of 2 on the width, I will decrease on 1.5 or 2 on the 8. But after that, I do the simulation software and I try to forecast what is the best. But generally, I have the exercise to do it myself first.
Why that?
Because
what means that you don't trust the simulation?
I do trust, but I know that for this moment the protrusion is more than in real life. But I'm quite confident for the next version, which will be more precise to determine the protrusion at the neck. But yeah, at the beginning we put two small devices. So from that experience and from the neck remnants we had for the first cases, now I tend to trust more my sizing at this time. But,
so quick question, quick answer. Gildas, web Artisse, do you use simulation or do you use the chart?
So I completely align with Cyril. Sorry, I like to have my own impression because I do the same. I know I have to oversize. I know I have to change the shape of the device, and I like to confirm with the simulation that I'm on the good track. But I do exactly the same as you do.
Monica?
Yeah, the same. First, I do it for my own with the sizing chart, I have to say. I find it very helpful. And then I use Siemens size. And the next version will be interesting because the currently version is really not showing the protrusion in an irregularly shaped aneurysm in the sac. Yeah.
So quick technical question is that specifically for the Artisse and the Siemens size software, you have two scale, which is apposition and compression. Can you explain around that?
Yeah, the compression it's very important to determine how the device will conform to the wall. So normally you have to respect the purple, color, which means that the compression is more than, I think 30%.
So there were many arguments against the web, which were roughly twice, which were necessity to have a lot of sizes on shelves and the difficulty to size the web. So there is no miracle in science. So do you have the same concern with the Artisse?
I have to say that for sizes, I didn't face so much cases where I was lacking of size, because for very big aneurysm, I don't treat with intrasaccular in general. And for very, very small, it means that it should be very, very small to not have the good size. And nowadays, I don't use, I put some very small webs, but it's quite rare in real life to lack size, in my point of view.
So I repeat the question. For me, it's not a difficulty to size a web or an Artisse, but we have to spend more time in sizing and looking at the vasosities and doing the treatment by itself. So I repeat the question to Monica. Is it the same? You have to spend a little bit of time to think about the size, or is it a concern for you?
It's not a concern because once you realize that you need to fill the aneurysm, you need to have the proper width, I think. Yeah, the oversizing in the width is very important. And then based on the devices you have, you can choose different sizes. Yeah, if it's a little wider, you can take a shorter one or so. So it's not so strict as with the web. You can change a little bit and you can help yourself with the sizes available, and that works nicely, I have to say.
Okay. Stagnation of dye. Does it mean something?
It looks like, because sometimes on the working incidents you have a very good stagnation, and on the final run, the aneurysm is gone. So I think
it depends whether it's a ruptured or non-ruptured. Ruptured, they are not prepared with antiplatelet treatment. So usually you have less stagnation of dye at the end of the treatment of a non-ruptured aneurysm. Do you have any insight for this?
I think you said a good thing. Once you see that it's not 100% good flow reduction, you replace it, and you see immediately flow stagnation. Yeah, in a ruptured, it's even more important. And I think this is something you can help. Yeah, if you know that the size is okay, but there's a little too much inflow, then just take it back and reposition it perfectly, and then it's usually gone. Yeah.
So you have repeated several times the word conformability. Mm-hmm. So I completely agree on the conformability of the Artisse, especially when you start to deploy it. Would that be a concern on the long-term follow-up?
I'm not sure that, because if you confirm both to the aneurysm more and to the neck, normally you should be able to treat fully the aneurysm. So let's see, but at this time, I'm not sure it will be a concern, this feature.
I have a very small criticism about what you said, is that you have to encourage the engineer to provide something fitting with a 17, because I do believe that using a 17 is always easier than using a 21 catheter as a rebar 18. Not for an MCE aneurysm, which is obvious to navigate, but when you have an angulated aneurysm. So do you still think that a rebar 18, you prefer the stability or you prefer the navigability?
I would prefer 17, but I would say that shaping with steam shaping may be very helpful for this kind of situation. But for sure, you need a good access. It happens that you are not very comfortable, so you add a Phenom Plus, for example, to gain support, to be less dangerous. Because if you push and nothing happens, yes, for sure you are lacking support, and you may add an intermediate catheter. But yeah, I will be more comfortable maybe with, if one time we have a 17, it will be great.
For everybody, or maybe for Gildas, you have seen this paper which was published some months ago in the GNIS regarding the sizing of the Artisse. Because of course you have the tendency to more laterally compress the Artisse rather than the web, meaning that you may induce some dog ear at the level of the neck. So do you have any advice how you size the Artisse to avoid having this V shape when you laterally compress a lot the Artisse, and to avoid having the dog ear at the level of the neck?
So for sure, that's a concern, because we are talking about dye stagnation, and I think I don't care too much about dye stagnation. I agree, it's a good feature if you have it, and if you don't. But I think what we need is neck sealing, and that's why I think Laurent's remark is very important, because you need to seal the neck. So sometimes I think you have to change the size, or sometimes you have to change the deployment location, but for sure you need a con-beam CT, and you need to confirm a good neck sealing, because this will bring you good results in the end.
Can we pull the device while it's already open?
Normally,
you recommend to partially resheet it?
I recommend to partially resheet it. Yeah, partially resheet it.
Same for you?
Yeah.
Okay. And you usually oversize the width of the Artisse, as we do that for the web?
The smaller it is, the smaller the aneurysm is, the less oversizing, and the larger it is 2 millimeters for sure the best. Yeah, and then I think you can play with the device to get it into that wide neck. Yeah, so I fully agree. You need to seal the neck, and I think you can play with the device to get this result. Yeah, this is also something which is not possible when has a given shape, I would say.
So at the level of a patient, I do accept that an MR is something which is perfectly acceptable. For clinical studies, I do prefer DSA, because the result is always beautiful on the MR. So for the clinical study, yeah, I do believe that MR is better. So what about finally, you have a new competition to the web, which is, again, very good. So finally, the enemy of the intrasaccular devices, mainly the web and the Artisse, are the coils and the clip. I would phrase that in the opposite side. I think that the enemy of the coils and the clip are the intrasaccular devices. Can you comment on that, Monica?
I would see it like that. So as you said before, I haven't used coils in the last years very often, only if I really had no other choice. And I think it's so much more easier and so much easier to teach it to the young ones. And it's so less stressy. I think, why should we still use the other things?
Would you have any specific indication for the web or for the Artisse, or maybe they address the same kind of aneurysms?
I mean, if an aneurysm looks like a web, it's perfect for a web, I would say. Really perfect. If it's a little irregularly shaped or out of the main access point, I would say, and the size is below 7 millimeter, I think an Artisse is easier to put it into the aneurysm in a complex shape.
So last question is about sidewall aneurysm. How do you foresee usage of a steerable catheter to be used in conjunction with the Artisse?
This would be nice, no doubt.
It would be nice, okay. So any other comment before we end this discussion to everybody? So thank you for your important insight in using the Artisse in the bifurcation aneurysm. Bye-bye, everybody, and see you soon.